As with usual at ASH, there are a lot of highlights. I think one highlight for me has been negative data. And negative data gets a bit less attention, but it does help guide the field and direct us toward strategies that, of course, will work and benefit our patients. And this often comes in the realm of large randomized trials. There have been a couple of randomized trials that I think reported out that were very important. One is called the Pyramid study. And the Pyramid study is derived on the basis that if we add a novel targeted therapy to R-CHOP, specifically in a high-risk population, that we might improve the cure rate with upfront therapy. And we also know that in non-germinal center-derived diffuse large B-cell lymphoma, also called activated B-cell type diffuse large B-cell lymphoma, that there's a heavy reliance on NF-kappa B signaling in the non-germinal center DLBCL patients, and that those patients treated with R-CHOP have an inferior overall survival to germinal center-like DLBCL patients. So that, as a foundation biologically, led to the idea that Bortezomib, a known inhibitor of NF-kappa B, should be combined with R-CHOP and compared to R-CHOP alone to see if we cure more patients specifically in non-germinal center DLBCL. So a randomized phase 2 study called the Pyramid study did exactly that, compared R-CHOP to R-CHOP plus Bortezomib. That data presented today at ASH shows absolutely no difference between the treatment arms. A good example of biologically a sound hypothesis that was not borne out in the setting of this clinical trial. There are several reasons why that could be. One reason is Bortezomib just isn't good enough a drug in that setting, and that's quite possible. Another is that the definition of cell of origin of germinal center versus non-germinal center using immunohistochemistry, as was done in that study, was not a robust enough differentiating tool in order to show a difference. And the other study is just that chance and patient selection failed to demonstrate that benefit. That said, Bortezomib does not have single agent activity in activated B-cell type DLBCL. So I think this study helps sort of hopefully put to rest the idea of Bortezomib in the upfront therapy of DLBCL. We'll focus our attention more so on other novel targeted therapies with more single agent activity for ABC disease, including the drugs lenalidomide and Abramson. Randomized studies incorporating those novel agents are ongoing but not yet reported at this time. Another study looking at Bortezomib in a randomized trial, we have known activity of Bortezomib as a relapsed agent in mantle cell lymphoma, and so a study out of the HOVON group looked at the question of giving everybody intensive upfront chemotherapy with R-CHOP, high-dose cytarabine, and stem cell consolidation with high-dose chemotherapy, and then randomized to maintenance Bortezomib versus no further therapy. A very important question with an agent with proven single-agent activity, this time in mantle cell lymphoma. That study, however, once again, showed no benefit in the favor of ongoing maintenance Bortezomib, and so Bortezomib should not be used in maintenance therapy for mantle cell lymphoma. Other ongoing studies of maintenance strategies, including rituximab, with or without lenalidomide, and potentially Abramson, are ongoing studies which may or may not prove benefit, but I think are promising to look at in the future. And then the final negative phase 3 study was in peripheral T-cell lymphoma, an unmet medical need across non-Hodgkin lymphoma, and one where we have a paucity of randomized phase 3 trials. One of the most promising agents there is the Aurora kinase inhibitor. That drug was compared to investigators' choice of novel therapy, and in that randomized trial, unfortunately, the Aurora kinase inhibitor showed no benefit whatsoever. In fact, it looked a little bit worse than the dealer's choice of standard available therapy, and so that drug will not be moving forward in relapsed peripheral T-cell lymphoma based on those data.